I'm seeing a lot of good conversations going on all around the building. How's it going so far? Pretty good? Good, I love hearing that. So I'm going to talk about the UCI experience now, and definitely, as I've been watching some of the lectures this morning, I've seen my thunder stolen left and right. So there's been a lot of people describing their own experiences and integrating in some of the stuff we did here, and so I think that's great. So, but hopefully this won't be too much repurposing some of that. It's all it's all timing, of course, with everything in life. But I did want to sort of talk about how we got started at UCI, and as an emergency physician, I did an ultrasound fellowship. In fact, I did the same fellowship that Dr. Blivus did 2 years after Mike did it, and out there in Chicago at Christ Hospital. And then I came back here to UCI, and I actually grew up here in Irvine. I went to Irvine High School and UC Irvine for undergraduate. Or I met my wife in a building that's like 2 buildings over from here. We worked in a research lab together, torturing rats, and as college students. And I have a lot of roots here at UC Irvine, and so when I went to medical school at Tufts, but then came back here to do my residency in emergency medicine, and then of course the fellowship in Chicago, and I came back in 2001 to start, basically doing emergency ultrasound, and what we then started calling bedside ultrasound, which is now morphed into point of care ultrasound, is sort of the term. All those terms are fine, but I like the point of care one the best. So inclusive, but so then. Right away, I started to see that it was nice having medical students around. Even really early on, like right after I came here, I just liked having a medical student on shift with me who had nothing to do but help me do an ultrasound. Like back then, the machines were a lot bigger, so they would like take the machine, bring it into the room, fire it up, and put gel on the patient, and try to get the image, and then they'd come find me and say, "Hey, I can't find the gallbladder," and then I would go in there and. The machine was already in there, the gel's already on the patient, the patient's name was already in the machine, I didn't have to do any of that, and so I was like, this is great, I get to do a little teaching, a little clinical decision, and I'm out the door, and then they would wipe the gel off, move the machine out of there, and go to the next room, and say, hey, bed 5 is, somebody short of breath, let's take a look at the heart. And so I loved that, and so I studied it, and we kind of did some pre-test, post-test stuff, and found that medical students could learn bedside ultrasound during their month-long rotation with us in emergency ultrasound, and they could retain it 6 months later. And then these medical students were fourth-year medical students, but they were going to all different specialties, not just emergency medicine. So then they would go to become an anesthesiologist, and I'd get an email, a year later, talking about how everybody was struggling to get a line in, and then they brought over an ultrasound machine or something. And I kept getting these stories over and over again from students that just were helping me move the machine around, and I thought, there's something to this, actually. Students are actually learning a lot here, and so are my residents. We did this study where my residents were doing more and more ultrasounds because there's a student there. So it was lowering sort of everybody's threshold to do point-of-care ultrasound back before the machines were, as portable as they are now, and so so it became an immediate benefit. But then, of course, the machines just kept getting more and more portable, and then it kind of made sense that I wanted to, sort of spread this to not just fourth-year medical students, but really more into the medical education. So I went to Dean Clayman, who you saw give a talk this morning, and I went to Dean Clayman, and I brought with me a portable ultrasound machine and a model, an undergraduate student, and I made an appointment with him. It took me 2 months to get a 30-minute appointment, which on the day of the appointment became a 15-minute appointment. He said, oh, you only have 15 minutes, and it was a Monday morning, and he didn't know who I was. I'd never met him before, and I walked into his office in 2009, right when he started, I think maybe 2010, and I said, hey, I've got this ultrasound machine. I want to show you how this works. And he goes, okay, shoot, and I just laid the model down on another table in his office, and I started scanning the organs. Of course, it went straight to the kidney, and I knew he'd recognize that one, and he didn't say much. He kind of looked, and then he took the probe and did some scanning, and then I did a quick survey of some other organs I could find quickly with the small footprint phased array transducer, and then it was like 7 minutes later, and then somebody came into his office and said, you need to come do this other thing. And that was it. I had 7 minutes, and he said, bye, and he left. And then, next thing I know, it's Friday of that week, and he wrote me an email, a long email actually, and said, of all the stuff I had to deal with all week, the little time I had with you on Monday morning stuck out in my brain all week long. That was the best part of my week. Let's talk about how to really integrate this into the curriculum. At the same time, I'd been in conversations with one of the manufacturers about trying to get a donation of equipment in order to fulfill a teaching mission here, to get enough equipment to really integrate it into the 4 years. And so those two things will sort of come together at the same time. I had top-down support, and I had some machines coming my way, hopefully, but I needed some money. And so Dean Clayman knew of this, the director of this foundation, the UniHealth Foundation, and said, you should meet with my grant. He has some grant writers. The university has these advancement grant writers set aside to help you with this kind of stuff. And I never really wrote a grant before, but he said, hey, I know this woman from UniHealth. She's looking for ways to really bring more clinical care to the bedside, and that's kind of her mission, is to get doctors back to the bedside. And you should meet with her and talk about ultrasound. So he set up the meeting, and then she wanted a proposal, and then those grant writer people just sunk their teeth into it with budgets and all that stuff. And next thing I knew, I had $631,000 to move forward with hiring the sonographers that you met today, Nora, initially Nora, and get some other stuff like simulation equipment and also protect my own time, give me a salary from the School of Medicine so that I could not work so much in the ER. So I took that money, the salary that came from the budget from the UniHealth proposal, I took that directly into the emergency department and just bought my time down off the schedule so I would have time to come over here and integrate all this curriculum. And then I got asked to talk at the Healthcare Management Academy, which is a bunch of CMOs, basically it's like 200 CMOs. They wanted me to come talk about clinically re-engineering what we do at the bedside. I didn't really understand any of this at first, but what they're saying is that in 2010 we underwent insurance reform, as we all know, the Affordable Care Act, and they're saying that by the year 2018 there needs to be a 25% cost reduction in all of healthcare, and the way that's going to happen is through scale and integration, some operational improvements, but the most difficult part of this is going to be re-engineering what we do clinically. And I heard that term again, re-engineering what we do clinically, and it got me thinking. I heard that from the people at UniHealth. Now I'm hearing it from all these CMOs. There's probably something to all this, and right about then is when Dr. Abraham Verghese, if you don't know who he is, he wrote that book, Cutting for Stone, New York Times bestseller. And I think doctors around the world sort of look up to Abraham Verghese as a modern day, William Osler. And he wrote the Stanford 25, the 25 things that Stanford medical students got to be able to do at the physical examination. And Dean Clayman saw it in the New York Times, calls me up all excited, says, we should do this thing like point-by-point comparison to the Stanford 25. And we did. And we took every part of that Stanford 25 and put ultrasound, compared it to it. And Gracie Maldonado is in the back. She helped me with the study. Dr. Shram Loptapor, our Associate Dean for Clinical Sciences, is in the back. He helped me with this project, as well as one of my medical students now, resident Joel Schlang. And so we called it UCI 30. We basically went through and we threw 5 extra things in there. And actually, Abraham Verghese himself does say in his Stanford 25 that ultrasound may one day be part of the white coat pocket. And so, with all due respect to him and his wonderful work, we were able to kind of get that out there in academic medicine. And then an interesting thing happened. In all of this stuff, you have naysayers come at you all the time with point-of-care ultrasound. You know who they are. They come from all different specialties. But I would say the biggest, one of the biggest sort of people I ran into was an ophthalmologist who read this UCI 30 from my own institution and became upset that I didn't include the Department of Ophthalmology, and basically because they were concerned about doing an ultrasound on the eye of a patient who was exposed to trauma, penetrating trauma, or blunt trauma to the eye, that ultrasound is contraindicated in those situations, and I failed to mention that in my UCI 30. So and I had to write a letter to the editor to that regards, and there's no way around it. So to remove blunt trauma as an indication for ocular ultrasound, but otherwise. It actually didn't really receive too much in the negative. I thought people were going to be coming out of the woodworks at me with the physical examination, and this is an abomination, and how can you do this? Ultrasound is going to distract students from what they really need to learn. It's going to put technology between them and the patient and all this stuff, and that never happened, actually. It was actually met with a lot of positivity. I had the slide earlier in one of my talks, but I love this slide because it talks about how we really aren't trying to pull away from the physical examination. If you have people who are really concerned about physical diagnosis, and just help them understand how ultrasound actually will improve the OSCE scores here with the physical exam. This is Dr. Dinh's study again, looking pre-ultrasound, post-ultrasound. Look at how the physical exam OSCE scores went up, and statistically significantly when it came to taking a blood pressure, performing abdominal examination, and being professional at the bedside. Ultrasound can definitely help. But throughout, there was red bars, almost on all of those were increased. Okay, so you got a pretty packed curriculum. How are you going to wedge ultrasound into it? That's probably the most common question I get whenever I'm talking to a dean from somewhere. The way medical school is currently taught, there's a professor at the bottom of the classroom bestowing their knowledge on a large group of people, which is a convenient way to teach a large group of people. But a more modern approach, of course, and according to the LCME, is really having at least 50%, I think, or 60% of medical school now taught through small groups and not through lecture didactic classroom format. And so we decided to flip that classroom when it came to ultrasound right from the beginning, and we took all the content and made podcasts out of it. They're free on iTunes. There's tons and tons of FOMED all over, FOMUS all over the internet now that you can get to help you in this process. USC has a bunch of University of South Carolina has a lot of good stuff. It's all out there. All our institutions now are sharing this, so it's great. So we decided to create our own and put it out there and make a curriculum, M1, M2, M3, M4, and put these podcasts up on iTunes for everybody to see those. And since we're all getting their iPads, as you saw from Warren and Julie's talk, it was kind of good timing there. Okay, so great. Now we have all these. The whole thing's flipped, but now we need to find some instructors. We got to find people out there who can teach this stuff. Where are we going to find all these instructors to break up into these little small groups? And it kind of gets back to Aristotle's teaching is the highest form of understanding. This peer-peer teaching, and when you try to explain something to somebody that you think you know cold, only to find out you have no idea what you're talking about. That's it. That's Aristotle right there, kind of getting that at you. And when I see my fourth-year medical students explain things to first-year medical students, I see them and they understand it in a way that now I know they're ready for residency. And it's at that moment that I think this whole peer-peer teaching really comes together, and it evolves into the graduate medical education as near-peer teaching, and then ultimately there's a lot of faculty peer teaching and student-to-faculty teaching that goes the other way. I mean, I know in my practice all the time, students are teaching me things and challenging me left and right, causing me to go look stuff up all the time. So we all know what that feels like. So where are my peers teaching these students? They're making their own podcasts. They just made some podcasts in Amharic. I have some medical students going down to Ethiopia to teach ultrasound there, and they took my podcast and translated the whole thing into Amharic, and they're doing that down there. So they learn how to make podcasts in that process. They teach on task trainers, healthy volunteers, and they do a lot of teaching on simulation devices, helping their colleagues find the pathology. But in one of the sessions we mentioned briefly today, how do I teach? I've got basically 100 medical students. How do I teach these 100 medical students every year? Like logistically, physically, how do we do that? So we have a course that runs all 4 years called Clinical Foundations. It's basically your history and your physical exam taking skills. And they have core teachers that teach that stuff to them. Most of them are in primary care. Now, let's say half the group is with their core teachers learning how to take a history and do a physical exam on a Tuesday. Those same 50 people are with me doing ultrasound on a Thursday, and vice versa. So you've got the other 50 on Tuesday doing ultrasound who are getting the physical exam stuff on a Thursday. So now let's break that down a little more. I've got 50 students on a Tuesday, and from 1 to 5 p.m., I break them into 4 groups. And in those 4 groups, I've got 6 stations. And in those 6 stations, I've got a model, standardized patient, so a patient, basically, and I've got an instructor. And we have those groups, basically 2 to 3 students per instructor for 1 hour. And over the course of a Tuesday and a Thursday, that's 8 hours where I took 100 people, broke them into 8 groups. Each group had 6 stations. Does that make sense? So those are the logistics, those are the details. And who are those instructors? They can be MS4s, they can be sonographers, they can be fellows in that peer group. So, but sometimes I hear this thing like, can peers really be trusted, sources of accurate information? Are they teaching them the wrong techniques? And so, seems kind of haphazard. Are you letting the inmates run the prison? I've heard all these things. Seems sort of a gimmicky way to reduce cost. And again, it all comes back to Aristotle, teaching being the highest form of understanding. But you do got to vet these instructors. And so I give them, they start out with a written exam, and then they go through some OSCEs. And on the OSCEs, I've got some simulation there. They're actually, with the SonoSim, where we put the tags on there, and there's pathology under some of those tags on some of the OSCEs and not some of the tags on the other OSCEs. So what happens is when they put that transducer on there, pathology will come up on the screen or not, and they have to integrate that into their OSCE. It's in addition to scanning a live model where they learn kind of how hard to push and how to use the as well. But this is a nice way to put the pathology in there. And in their third year clerkships, as mentioned, we have OSCEs on 3 of them. We have a 4th one coming up right now that we have during their third year clerkships. And so we talked a lot about OSCEs in another lecture. I won't go into that. But then they go into more electives that the students themselves have designed. And again, this gets back to, it all comes back to LCME, their latest definition of, quote, active learning. They're kind of changing that term. They're getting away from the term active learning. Actually, they're getting more to this term called self-guided, self-directed group learning. And so that the students come up with their own learning objectives, and then they figure out the ways to meet those objectives and learn them. It's very self-guided, self-directed. And I mean, the students came up with these electives that you're seeing here. Talk about self-directed. They came to me with this idea, and they call it Bedside Sonography, Ultrasound Education, and Community Outreach Elective. And they go through the sessions. They created the whole thing. So they do these electives. This is kind of how I vet who's going to be a good teacher. They created a 3rd-year ultrasound elective in the ICU. They created a 3rd-year ultrasound elective in OBGYN. And basically, through that, I'm able to see who's really showing up and being committed to ultrasound. They also do a lot of research, both research on how to use ultrasound clinically, but also research on how we're using ultrasound in an educational way. They take ultrasound to different countries, and they study the educational process down there. Like the students going to Ethiopia are doing a pre-test, a post-test. They're comparing live lectures to simulation and to flipped classroom material, and see if people all retain it the same way or not. And then they go back to these countries a year later and they test retention. We've got this student here, Brad Jacobson, right here. He goes to Tanzania every year. They're having their 3rd trip to Tanzania coming up. He does a lot of longitudinal educational studies there. Cosmin went to Transylvania and took a group of students there, and they learned, they did a lot of pre-test, post-test educational research there with their medical students. And then ultrasound interest group, you've heard a lot about this. I don't need to belabor this too much, but back in September, we had the World Congress of Ultrasound and Medical Education at OHSU, Dr. Mladenovic's location, and University of Kentucky took 1st place, and go Jen Cotton, and she's representing, and then Oregon Health Sciences took 2nd place, and then so OHSU was 2nd place, and then they couldn't decide who's going to be 3rd place, and so what they did was they did a dance-off to see who'd get 3rd place, and dancing to see everybody, my UCI students, they're wearing these gray shirts right here that they created. And through this dance-off, and I'm happy to say, very proud actually, here they are, my UCI, actually they won, they call it the Bronographers, and they won the 3rd place, which to me was the most important thing to win there. So I'm very, very proud of them. Never prouder of a moment in my career. So the students have gone. They raised a lot of money to go do some travel. They created a 15-minute presentation on their own. I had very little input here. They worked with one of our advancement people to put the finishing touches on it, and Chanel and Brian Sloan. Chanel's here, you've seen her speak today. She and Brian Sloan got up and gave a talk to a donor for 15 minutes, and then they had $100,000 at the end of that talk. The guy said, yes, absolutely, $20,000 per year for 5 years, let's do this. And so, again, I got out of their way, I let the students drive that, and it was amazing. So they went to all these countries you can see listed here. This summer they're going back to these places as well, and a couple of new places. So it's been a lot of fun. And I want to talk to you about just to showcase one of those locations here is with the Floating Doctors. And this is an organization that goes down into Panama, the Bocas del Toro region. And we've sent students down there now, probably, what do you think, Chanel, 5 or 6 times now at least. They've gone down there and they teach a lot of midwives or parteras how to use ultrasound in this in the jungle here. And they go up in the hills. And basically their goal is to
Today we are in Valle Escondido. I'm just accompanying the group of UCI students that are introducing the sonogram to the parteras, which is Spanish for a midwife.
We're here to train parteras through Floating Doctors to use ultrasound. And because of Sonosite, we're able to get a very clear image, which helps us train these parteras to scan pregnant women.
They've never seen a sonogram before. A lot of them don't go to the hospital to give birth. They do it in the home. So I think the main goal of this project is just to introduce the machine and then kind of an interchange of what they do as parteras.
They also performed a study looking at hypertrophic cardiomyopathy where they take their machines, they take about 20 machines with them, and they go out in the community, high school, during a physical exam for students students participating in athletics. During that same time, there's like 150 students lined up to get physical exams by a family doctor. They have their machines set up over another part of the gym, and they're screening the patients in a parasternal short axis. And using M mode, they learned through a pediatric cardiologist we all learned how to measure for or screen for this study. We can do this in under 2 minutes reliably now per student at these stations, and we feed all the data back to cardiologists. And we've had about 60 false positives where we bring the patient back and do another freebie ultrasound on them, but then 5 true positives where we really made a difference there. And 1 in 500 is the rate of hypertrophic cardiomyopathy in the population, so our numbers are right there. A physician came along the way, Janice Boughton, who is a family doctor who does a lot of international relief work with ultrasound, and she spent a month with me learning more about ultrasound, and now she acts as a chaperone for my students in these far-flung locations and did a cool study with malaria in Tanzania. I've had students go down to Australia. We created a whole collaboration with the University of New England, and we got a lot of grant money from them, from the National Broadband Network of Australia, and installed a lot of high-definition conferencing equipment so we can not only do a lot of asynchronous learning. This is one of my students, Danny Lama, down in Australia, teaching an Australian medical student here. Not only to do this asynchronous kind of thing where they watch podcasts and then get hands-on, but also to do synchronous learning when you're connected up with the Polycom system. And Dr. Yum and Weekman et al. Wrote an article about that process of teaching ultrasound, where there's an ultrasound feed coming out of my ultrasound machine and coming out of their ultrasound machine down in Australia, and also there's a camera on the probe position. And it's very like real time when you have the right pipe, a big enough pipe to get the data back and forth quickly. I mean, it's like they're in the room with me in high definition. It was pretty cool. So that's something to think about if you have other hospital locations where you cannot be on site. And there's a lot of people out there, they have a medical school, but then the students get scattered around to 18 different hospitals. So there's a way to do this synchronous learning as well, where you're actually teaching hands-on this live. And so UltraFest, there's been a lot of talk about UltraFest. We've written about it. We've sort of documented
Irvine.
it here.
Beautiful day today. I'm here with Kaya and Heather. And medical students here today have a very special thing going on. It's called UltraFest. So Kaya, how about you tell us a little more about what UltraFest is about?
This is the 3rd annual UltraFest at UCI. I was actually here and worked with Dr. Fox to create the first UltraFest 3 years ago. And it's really just to expose medical students to ultrasound. And we're really fortunate at UCI because Dr. Fox and a lot of our other faculty have supported so much with ultrasound and really integrating into our program. So we have the advantage of getting a lot of training in ultrasound, which we're all so excited about. And a lot of other schools haven't been fortunate enough at this time to really have this much exposure and this much training before residency.
That's great.
In ultrasound. So we really wanted to share our wonderful facilities here and all of our wonderful instructors, and even our students are really becoming instructors now.
Basically, this is going to, so you don't need to keep hearing about this.
We put on the ultrasound
You wanna hear
elective
about
that we run for our first
Janelle's
and second year
experience,
students. We help organize a lot of the international outreach programs, a lot of the community programs. We help with Ultrafest, obviously, and I think what we try to do is just drive our passion into every field and aspect of medicine, which can be all-encompassing if you really apply ultrasound in the right way. Ultimately, my dream is to be able to use ultrasound internationally too, and just really educate and empower other physicians, clinicians of any type to use ultrasound just to help better diagnose and teach their patients, and really just help with the whole process of healing. And I think that's what's so powerful about learning ultrasound in medical school versus maybe residency or even after, is that the earlier you start, the more confident you are, and the more training you have, and the more pathology you're exposed to. And I really think that ultrasound would make anybody a better physician.
So I try to get out of the way of the students any chance I get, and hearing their message like that can really go a long way with your other administrators. But she mentioned something important. I don't know if you caught it, but she said, no matter what kind of doctor you are. And that's really an important take-home message, is that to really make this work, you need to have a multidisciplinary approach to make this whole curriculum work. This is Dr. Devinder Ramsingh. He is a colleague of mine here. He's an anesthesiologist who does a lot of cardiac ultrasound. He did a cardiac anesthesiology fellowship at UCLA and just fell into my lap here at UCI. When he came on staff, I just wanted to hug him and never let go, because he does so much good teaching of our students in his whole world, which is regional nerve anesthesia and a lot of great cardiac physiology, and just takes it to the next level with those guys, and is an amazing colleague for me there. And it's great because, you could really get a sense of, this is him sort of teaching here, and it's just been really great working with him and a lot of other colleagues around the institution. But specifically, you can find these people. He even wrote a paper about how to really get this point-of-care ultrasound to be more embraced by anesthesiologists. Working with our family doctors as well, the primary care doctors, the medical students who are going that way into primary care. This is an area that is just ripe for development, point-of-care ultrasound in that specialty. But again, I think the take-home message here is just find your champions in various specialties, and don't be surprised when your students become the teacher. This happens a lot actually throughout the hospital, where the student will uncover something and they have to usher in an explanation around them to really get the people around them to rally and understand that there's an important finding. And sometimes they're wrong. Sometimes it's not an important finding, and it's up to us to be able to usher in a clinical explanation of why we're not going to perform more imaging. And as you've already seen, we do a lot of, I think another sort of benefit from all this is all the outreach that happens in the summertime when the students are not in the building. As you can see, the building's been pretty empty right now. My current second years are really third years now, so they're all over at the medical center. And my current first years today, they took their anatomy shelf final. You'll probably meet some of them today in the afternoon session here, but they're done, and then they're going to be looking for stuff to do this summer. And there's a lot of good stuff that we get to, a lot of good outreach that we get to perform in the community all summer. So I'll just end on this. This is a policy that our legal counsel came up with. Something that's one of the main questions we get asked is what happens when a student uncovers something at the bedside. And it's really the first thing when they do an ultrasound on a patient, they're to explain that they are students and they're not the treating doctor, and that they get permission to perform an educational ultrasound. And then the students aren't sharing those findings with the patient until that's done during rounds with the attending physician. And then the students save their images, and they get that workflow comes through one of our the ways that we can do that with our image archival software. And all their images can get stored this way, either here or at the hospital. And we review all those images, and then on a weekly basis, and then we delete all the ones from the students once they've been reviewed. But this is the important take-home message here. It's the last one here. Any student who believes they have uncovered an unexpected finding on ultrasound is required to immediately report this to the attending physician, who will determine if clinically relevant. Now, you can imagine the medical student maybe doesn't have the political gamut yet to walk up to the attending physician and go, hey, this patient's got a pneumothorax, or some other finding. And they just don't feel like they can usher that explanation in just yet. So I make myself like incredibly available to the students 24 hours a day. My cell phone is on the bottom of all my email attachments. And I'm like, I mean, the students will tell you, like, you can text me anytime you want about any question. And that's something that I think is important for them to always feel. In fact, the rest of the faculty to always feel like there's that safety net there. But, you know, as more and more residents are obtaining this skill, that the students are feeling more and more comfortable talking to the resident also about their findings. And, you know, we have a subcategory under 6 where they can go up the ranks through the residency supervision before they get to the attending. But at any point, though, we want to make it clear to them they can go to the attending if they want, or come to me with any questions. So I think it's important to, one final thing I want to say is I rode the bus this morning here from the hotel, and I was sitting next to somebody from another institution, and she mentioned that initially they had ultrasound in the curriculum, and then something happened. They took it away from the students, and the students like went ballistic and wrote a whole thing about it. And so you really can't, once the probe is in their hands, you can't rip it out. They're there. This revolution's happening, and there's no way to tear it out of their hands when you're done. The cat's, you know, what is it? The horse is out of the barn. You know, the cat's out of the bag, you know, that kind of thing. Like it's done. Like they love it so much because they feel so useful with it, and as you can see, all the enthusiasm left and right. It's definitely the right thing to do. So if the top-down approach isn't working, then you've got the bottom-up approach for sure. So before we break up into our small groups, I do want to bring one thing to your attention, and that's this piece of paper right here. I don't know if you have it in your packet or not, but this is what AIUM uses. And you can use as well. It's like a carbon copy thing. Remember how you write on one side and it goes to the other? Like the old medical charts before they were electronic. So if you could just put your name and your institution on the top of there and fill out 3 things that you learned, actions you'll take, resources that you need, and next year stuff you want to learn about next year. Keep one for yourself and tear the other one off. You don't have to do it right now, but at some point today, I can't tell you how helpful these things are to us at AIUM. AIUM spent a lot of resources getting you all here today in this building, and I just want to thank AIUM at this point while I'm still here on the mic. Thank you guys very much for all the organization and the financial resources that went into this. I think that's just been, I mean, amazing. So thank you guys so much. Awesome. I'm sorry? So, we have another lecture. Yeah, so we have another lecture right now. So downstairs is going to be multi-specialty approach to ultrasound integration in the 4th year, Drs. Bonner and Hupman. And if you can load those on the thing downstairs, great. And then the second lecture, the one in here is going to be Dr. Blyvis talking about leveraging simulation and multimedia education to augment ultrasound education delivery with limited faculty. And then at 2 o'clock we break up into those small groups. And on your name badge you have a small group listed, a number there that you'll know which room to go to based on your name badge. We'll be downstairs helping to facilitate the small groups as well.